Welcome to Sword and Shield, the official podcast of the 960th Cyberspace Wing. Join us for insight, knowledge, mentorship, and some fun as we discuss relevant topics in and around our wing. Please understand that the views expressed in this podcast are not necessarily the views of the U.S. Air Force nor the Air Force Reserve, and no endorsement of any particular person or business is ever intended.
All right. Well, good day, gladiators. Thank you for listening to another episode of the Sword and Shield podcast. It's Francis Martinez, Director of Psychological Health for the 960th Cyberspace Wing. And I have two very special guests with me on the line. So I'm going to turn it over to Lieutenant Colonel Emily Rucker to introduce herself.
Hello, I'm Lieutenant Colonel Emily Rucker. I am an Air Force reservist working in the 16th Air Force Surgeon General's office.
And your discipline is a Doctor of Psychology, correct?
Correct.
All righty. And thank you for joining us today. We also have Dr. Soad Mitchelson. So I'll turn it over to Dr. Mitchelson.
Hello, everyone. I'm Soad Mitchelson. I am a board certified psychiatrist in children, adolescents, and adults. And I am at San Antonio Behavioral Healthcare Hospital, medical director of the outpatient services.
So thank you both for joining us. It seems like it's been only a couple days since we last spoke. So for those listeners out there, we did have a Mental Health and Resiliency Fair, and both Dr. Mitchelson and Colonel Rucker were on our panel as our medical panel of experts. And so today's podcast, we just kind of wanted to recap on the event. It was a very large, successful event, and there's a lot of questions that unfortunately we weren't able to get answered during the panel. And so we want to, afford that time now to be able to do that. So thank you guys. I know it was a very busy weekend. Overall, we had over 1,200 people, both virtually and in person. So we're looking forward to next year for sure. But here are some questions that we had just unable to answer. And so for Colonel Rucker, some folks want to know, what are some good coping strategies? And a follow-on question for that, we hear journaling and things like that, but some people just don't know how to journal or what that looks like. So what do you think about some good coping strategies?
Sure. So I think there's a lot out there. I think the challenge for a lot of people, right, sometimes is that they think of coping strategies and they don't consider that they may already be doing some things that are actually just are naturally inclined to do. A number of people enjoy some sort of physical activity that doesn't have to be a major physical challenge. It could be getting out and walking or dancing of any sort. Just kind of getting your body moving is often something people do to just kind of manage whatever's coming up day to day. Another thing, right? A lot of people, whether it's meditation or prayer, that tends to kind of give them a chance to spend some time kind of just contemplating or considering, kind of focusing their attention and their mind. That can often be really helpful as well. And again, it doesn't have to be in any one prescribed way. The other thing you mentioned, right, with journaling, this idea of writing and just kind of writing how you're feeling or what's going on. There are a number of people who like to do that. Some people say journaling just doesn't come natural to them. So an alternative might be creative writing or poetry, drawing. It really can be anything that you just enjoy doing that helps you just kind of take a moment to relax. So I would really encourage people to kind of just look at what are things that they just enjoy doing when they do have the time, and maybe make a little extra time for those activities.
Yeah, I know when I work with some folks and we talk about journaling a lot, right? And then you're kind of reprocessing and rejournaling. But again, not everyone's a writer. And so part of that, I asked them, well, if you can't write it down, drawing or sketching or painting, some other method of just to show how you were feeling in the moment. Music is always a great option as well. And so I think that's how a lot of folks, they don't realize that, hey, these are good coping strategies that I'm using. They just think of it as, you know, something they always do. So adding some intentions behind what they're doing.
Absolutely.
So Dr. Mitchelson, one of the questions that we had received for teenagers and young adults, what are the best methods to use to increase self-help skills? So asking for help, recognizing triggers, areas they don't know how to cope with.
Well, one of the most important things is to improve an insight. And insight is basically what it means is knowing yourself. So as we grow and we progress developmentally, it would be very helpful for parents as well as teachers, you know, in the school system, to help the kids start knowing themselves, acknowledging their emotions, acknowledging their behavioral responses. The important thing that comes out of that is in the teenagers and young adults is if they start having negative emotions or they feel like they're frustrated and can't move on or find a solution to what they would consider as a problem, then they learn how to seek out help. Now, one of the biggest self-help skills is to be able to acknowledge when one is struggling, to be able to reach out to others. And that is a very important skill for actually all ages, but especially for teenagers and young adults.
Yeah, we had a brave teenager stand up during our event and, you know, asked, you know, if my friends are needing help and I'm needing help, how do we go about getting that? And what happens if they don't want that help? And that was a pretty powerful move. I know that Ms. Zaya's got a lot of recognition for that, just for the bravery for standing up and asking that type of question. But I think that a lot of kids are scared or they don't think that they need the help, right?
Definitely. They can't identify that something's going wrong. And actually it's more of they can identify that something's wrong, right? They have these kind of negative feelings, whether it's sadness or anxiety, or they just feel even physically sick. But they don't know what it is. And so they feel that they can't reach out for help unless they know what's going on. And so it's important for us to learn and teach our teenagers and young adults as well as ourselves that you don't have to wait to know what's going on. If you feel some discomfort, be able to reach out and have at least one person, one adult, one person that can respond, that's identified so you can discuss things with them. I can't tell you how many times I hear from teenagers that they have been dealing with negative feelings, call it depression, call it anxiety, even suicidal thoughts. But they never said anything because they thought that was what they call normal, right? They've been experiencing it for such a long time. They didn't know that they needed or could ask for help.
And here's the second part to this question that that one of our service members asked. So what are the common or frequent reasons that teenagers and young adults are seeking help or being directed to get help?
Well, definitely when there are safety concerns. We should be able to seek help before, and I'll speak to that. But the first and most important, let's say, idea or emotion or feeling that needs help and needs to be addressed in any milieu is thoughts of hurting oneself or thoughts of hurting others, or even to the point where they're feeling like they're hearing voices that are telling them either way to hurt themselves or hurt others. Those are let's say, symptoms that need to be responded to immediately. You don't really have to figure too much out. You just have to find someone that knows how to manage them to be in contact with the person that's experiencing that. But the idea is that with education and decreasing stigma, we can help people reach out, right? We can help teenagers, young adults reach out before they get to that point, when they're feeling like they just can't function in school or not functioning as well, or things are happening with their friendships, right? Like they're losing friendships. Or even the young adults, they're struggling with jobs they could do before.
Mhm. Yeah, and so the next question is going to be for Colonel Rucker. It's a two-part question. So, can a commander direct a member to mental health treatment? And do you tell my commander or first sergeant what I'm saying in therapy?
If you're on active duty orders or on active status and it's emergent, the commander can direct if they have a reason to believe, and a reason to believe meaning a statement, a behavior that would suggest there's an imminent safety risk for that individual. They can direct that person for a mental health assessment to ensure safety. And they have to not only provide the evidence of behaviors to the mental health clinic. They just can't say, I kind of have this general idea. They have to explain to the mental health clinic what specifically is giving them cause to believe there's an imminent safety risk. And that instance they can direct. The other instance where they could direct is if someone is demonstrating behaviors or symptoms that are consistent with a mental health issue that is impairing their ability to do their job, their military job. And in that instance, they can request what's a routine commander directed evaluation. Again, they have to talk to mental health in advance, provide what it is that is leading them to believe there might be a mental health condition, how it's impacting the job. And then once that's verified that it's appropriate, the process can begin. And again, that's also to assess whether there's a major safety issue, whether there's a significant mental health issue that's impairing someone from doing their duty that needs treatment, or if there's not a mental health issue and the issues aren't related to mental health at all, they at least then have kind of ruled that out. But it also then gives the provider gives commander recommendations on how to support the member if there is a condition and recommended treatment. In terms of if you're engaging in regular treatment, say at the MTF, at the mental health clinic, there are certain only specific circumstances during which they can speak to your commander about your treatment. So that would be, they have a mandatory notification if you disclose certain things, or they can talk to your commander if you give them permission to talk to your commander and you sign a release of information. So the commander only gets information on a need to know basis, and those instances are described in the informed consent that you would review and sign before you start treatment, or if you give permission for the provider to speak to the commander, and then you can give specifically what you give them permission to speak to your commander about.
Gotcha. So I know we've had some questions around like once the recommended treatment is there, can continued or that commander direct actual treatment or just the evaluation?
No, the commander can only direct evaluation. They cannot direct treatment. So the commander can direct the evaluation if they meet if the situation meets the criteria for a commander directed evaluation. When the evaluation is done, recommendations are given both to the individual and about, recommendations from a mental health perspective about, we would recommend treatment, this type of course of treatment or whatever it might be. It is still up to the individual whether or not they want to pursue that treatment. They cannot be forced unless they are an imminent risk to themselves or others and need to be hospitalized. That's a whole different conversation. But if we're talking recommendation that they engage in outpatient therapy, that is still voluntary. The individual can decline to engage in that treatment. Now, there might be some ramifications because of that, particularly if the individual is experiencing a condition that really necessitates treatment. There may be implications if they choose not to engage in treatment, but that would also likely be a discussion when the individual says, well, I don't really know that I want it. You know, the provider or the evaluator will be explaining, or should be explaining, kind of, hey, well, here's what potential implications are with regards to readiness without treatment. So they will facilitate a educated decision on the individual's part.
Okay, and then, so I know in the beginning, you said active duty or those that are on orders. So can a commander direct evaluation for a traditional reservist? Is that only during drill weekends or while they're in status? If they get a call and it's kind of sounding concerning during the week, for instance, and they're not in status?
So if it's drill weekend and something arises where there appears to be an imminent risk, the commander, particularly if it's, down in San Antonio, since there is SAMC and they have an emergency room, if it's drill weekend and the Lackland MTF's not open and there is an imminent risk, they could command direct an emergency mental health evaluation at the SAMC ER, specifically for safety concerns. It wouldn't be for traditional, just non-emergent concerns. It would purely be if there's an imminent safety concern on the individual. They could command direct the person to the ER and do it that way. If, again, UTA weekend and you're in San Antonio. If you're on inactive status and you're, in your day-to-day weekday life, there's no drill weekend going on and there's concerns. So there is an assumption, there is a presumption of fitness when you show up to UTA weekend. So the military has a presumption of fitness, which means they're assuming when you show up that you are medically and psychologically fit and healthy. If things have been going on in the time that you were inactive, you are supposed to report those to your medical resources or your medical support, because if you need to be on a profile or you need support or it's going to impact your ability to do your job, the military wants to be able to support you and address that so that one, you're taken care of, and so that two, they're also then aware what might be impacting your readiness. If you just happen to have a crisis in the middle of the week, again, the commander isn't necessarily, you're not in touch with your commander, the commander really can't kind of direct it. Ultimately, hopefully someone around you may recognize that there's an imminent risk or there's a cause for an emergent concern, and they may try encourage you to go to the ER or be willing to take you, or they can call law enforcement if they need, if there is an imminent concern, like you've stated, you're going to hurt yourself or someone else, and law enforcement may come out and then facilitate an emergency mental health evaluation. But that, again, is that wouldn't be your commander. That's just kind of separate in the civilian sector.
Yeah, and so just a reminder to our listeners, the Ask, Care, Escort model, right? ACE model, being able to ask if someone is a danger to themselves or others, if they are suicidal or homicidal, providing that care, never leaving them alone, and escorting them to whatever facility, ER, contacting 911 if it is an emergent crisis. So Dr. Mitchelson, the next questions are for you. It's a three-part question. So I have a family history of depression and anxiety. Does that mean I'll have it or my kids will have it?
Not at all. When we ask about family history, it is because there is a genetic predisposition, but genetic predisposition means that there's a higher chance in certain situations that the condition like depression or an anxiety disorder will present, but it doesn't mean that it will. In other words, just because your mom or dad had an anxiety disorder or a depressive disorder, it does not mean that the children are necessarily going to present. But the important thing is to know your family history. So, for example, if there's high blood pressure in the family, it doesn't mean that everyone's going to have high blood pressure, but you want to take care of yourself so that these symptoms don't present themselves. It happens in physical situations or physical conditions, just like it happens in psychiatric conditions.
Okay. And the next question, to piggyback off that one, if I start taking antidepressants, will I need them for the rest of my life?
So antidepressants are a treatment for very different conditions. For example, depression, anxiety. And so the way that kind of the baseline way of looking at this is you take the antidepressant is recommended, the patient takes the antidepressant. From the moment they start feeling well, there's a recommendation for a 6 to 12-month maintenance period, which is very important. And people kind of forget because they start feeling good. And so they go, I'm feeling good, and they stop their meds. But if the recommendation is a 6 to 12-month maintenance, at that time, if the person is asymptomatic, which means no symptoms, or they're functioning where they would like to function, things seem to be going well, then the medication with the guidance of the psychiatrist is tapered off. The continuation of follow-up is very important, even if they're not taking medication, to try to make sure that the person continues to be stable or symptom-free. So the answer to that is no, antidepressants are not for the rest of your life.
Awesome to hear that. I know that's one of the misconceptions or the fear that I hear people, not wanting to take medications because I don't want to be on it for the rest of my life, or I don't want it to further disable me, right? They feel like that's a disabling thing. The last question is, I've been referred to TMS. Can you tell me more about it? And what is ECT?
Okay, so those two, TMS, those TMS and ECT, so those two are procedures in psychiatry that can help with depression or obsessive compulsive disorder, or even individuals that have some chronic conditions, especially if they do not respond to medications. So TMS, for example, is a procedure where there is a magnet pulse that goes through the brain. It does not hurt. Very, very low side effects to it, maybe headache that goes away pretty quickly. And it's a session, it's about a 1 month every day, except for like weekend sessions that you do for about 45 minutes. Now, there are different types of TMS that are coming out now, so the sessions could be much shorter. They could also be decreased in time, as in duration of the day, or time that or amount of sessions that have to be run, but along with medication. So this is the important concept also. Along with medication, it can help with depression as well as with anxiety, obsessive compulsive disorder. And there's a lot of research being done with TMS. Now, ECT is another very important procedure. It's a procedure that it's electroconvulsive therapy. It can sound pretty scary. A lot of people, when they hear this, they go, "Oh my gosh, this is the old-timey kind of shock therapy." Well, nowadays it is very, very, very controlled. It's controlled by an anesthesiologist as well as a psychiatrist. And when I say controlled, it's not dramatic. It does produce a type of seizure in the brain, but the person is completely unconscious and they're not moving. So there's no seizure movement that is occurring. Now, the big importance to ECT is that it is very effective in treating very, very difficult and severe depression, as well as difficult to treat depression and bipolar disorder, or depression and schizophrenia. So although those two procedures because people don't know them very well, seem very scary. They are very effective treatment when medications alone are not helping.
Yeah, and I know you said ECTs, electroconvulsive therapy. Just for our listeners, TMS refers to transcranial magnetic stimulation. So it's recommended from physicians, right? It's a pretty hefty referral process. But if you're interested in that, we do have facilities and we can give you recommendations to talk to your physicians about if that's something that you are interested in receiving. I know we can go on for hours about, the some more of these questions or the conversation of mental health, and May being Mental Health Awareness Month. It is, very important for us. And so I just want to thank you both for joining me today and joining us, for our event. And I hope that we can continue to try to destigmatize mental health, educate folks, and really get on that forefront of this and be on the wellness end instead of the illness end of mental health. So thank you both for joining.
Thank you for having us.
Yeah, for our listeners, if you or someone you know are contemplating suicide, please contact the National Suicide Hotline at 800-273-8255. And just an FYI, beginning in July, the number is changing to 988. So in July, the crisis line will be 988. So again, I appreciate both of you, and Gladiators out.